the original origin of physicians, because in the United States, I mean, physicians were really, they were the class of people that were either doing butchering or they were doing haircutting. It didn't get corporatized. It didn't become like medical school with corporatization until people decided that they wanted to sell drugs and they needed high-priced salesmen for these drugs. There was a way to indoctrinate a sales crew into it and keep a separation between you and the sales crew. And the sales crew makes their money, but they sell your product. They just don't realize it. Almost everything that we do in medicine is driven by these large agencies that are trying to figure out how to sell more drug.
Welcome to the Plant-Free MD podcast with Dr. Anthony Chaffee, where we discuss diet and nutrition and how this affects health and chronic disease, and show you how you can use this to optimize your health and happiness, both mentally and physically. Hello, everyone. Thank you for joining me for another episode of the Plant-Free MD podcast. I'm your host, Dr. Anthony Chaffee, and today I have a very special guest, Dr. Gurpreet Padda, who I met in San Diego at the Symposium for Metabolic Health. He is a pain specialist, and he has very interesting views and revelations on that. So, Dr. Padda, thank you so much for coming on.
I appreciate it. Thank you.
So, for people who haven't come across you before, can you tell us a bit about yourself and what you do?
So, yeah, I'm a interventional pain physician. I started my world in surgery at Cook County in Chicago, but then converted over to anesthesia and then interventional pain. I've been in the field for over 20 years. I practice in the urban core of St. Louis, which happens to be the #1 capital for gunshot wounds and trauma, and also for murders in the United States. So it rivals Somalia. So I'm in the urban core, and I deal with a lot of the urban core issues. And I've been treating in this area and trying to figure out how to help patients. And over the last 20 years, I've come to some conclusions that are a little bit opposite of where we thought we were with pain management.
Okay. So that was something that we were talking about, was that you have a very different approach to pain management. You know, there's a lot of different tools in the shed for pain management. There's medications, there's injections, there spinal stimulators, things like that, all sorts of different things. But you take a slightly different approach, don't you?
Yeah. So historically, we initially thought that pain is a symptom. And in about 25, 27, 28 years ago, the pharmaceutical industry got involved and they said, oh, no. Pain is not a symptom. Pain is a disease. And they said, we have a medication that treats this disease. It's called a narcotic. And we have a variety of these narcotics, and they're moderately expensive, but you as the physician should use these narcotics. And they pushed those narcotics out to initially pain management doctors and then to everybody, saying, hey, these things are totally safe. Anybody can use them. And so that's became the OxyContin issue. And everybody thought, well, it's a disease, just like hypothyroidism is a disease. So I just give the patient the pain medication, it's going to fix the disease. But that's not the reality. Pain is the symptom. So the IASP, which is the International Association for the Study of Pain, has like 6 criteria, and it's a biopsychosocial model of pain. That's not my definition. My definition is 1, which is pain is the final pathway. It's the body screaming that something terrible has gone wrong and you got to fix it. It's your alert system, and everything else feeds to it. So I don't care if you have multiple sclerosis. I don't care if you have diabetic neuropathy. I don't care if your limb got cut off. I don't care if somebody poked you in the belly with their thumb. It hurts. And it's an alert system that says, quit poking me in my belly with your thumb because there's something wrong. Now, if you use the original way that the pharmaceutical industry was pushing it, you have a pain symptom, take this narcotic, it'll cover up the pain symptom. And then once your body habituates to that narcotic, then we're going to give you more narcotic. And then we're going to give you more narcotic. Now, there's something interesting that happens. The body has a natural endorphin system. it produces chemical compounds that stop the pain on their own. And if I give you outside narcotics, the body stops producing those endorphins. And so the more narcotic I give you, the less endorphin you produce, the more dependent you become on the narcotic. And then eventually you start to do hedonic substitution, because that's the nature of creatures. That's the nature of human beings and practically all animals, is they start to self-stimulate and they figure, hey, this makes me feel good, so I'm going to start taking more of this. And thus begins the beginning of addiction. You're stimulating and it's hedonic substitution, and you've got an addiction issue now. And so my model goes against that and says, look, let's restore the endorphin production. Let's use pain medication judiciously as needed, but the least amount possible, so you can maintain endorphin production, and then try to figure out the root cause of your symptom and unwind it. And so I'm an interventionalist. I do all kinds of procedures and stuff, but my goal is to minimize my procedures and minimize my narcotic and restore health. And that's typically through a lifestyle mediated approach globally.
Okay. And so what is your sort of lifestyle approach that you would enact for your patients?
Yeah, so it's a combination of things, but the fundamental thing is all of the things that are associated with healthy living. And so people talk about a Mediterranean diet as being healthy. I don't view the Mediterranean diet as a Mediterranean diet. I view it as a Mediterranean lifestyle. So ideal amounts of light, ideal amounts of activity, ideal amounts of interaction with other human beings, and eating in a way that's consistent with our biology. And our biology is that we're apex predators. We have a pH in our stomach of 2. We're not herbivores. We don't have a ruminant stomach. And certainly we can consume vegetable matter, but that's not what we're designed for. We're designed primarily to eat rotted flesh. We're designed to eat rotted meat. We were the tiny creatures on the Serengeti. We were the tiny creatures that lived next to the ocean that would break things apart and eat the saturated fat. And we were obligate heterotrophs. We could absorb the nutrients of other creatures, and that's what built our brains. We were not the creatures that could consume pounds and pounds and pounds of fibrous material and turn it from fibrous material into short chain fatty acids in our ruminant stomach. We don't have that. And so when we eat a bunch of vegetable matter, we start to get bloating and we don't feel good. And we need a lot of saturated fat. We need a lot of protein. We don't need a lot of fibrous material that we can't metabolize or do anything with. Now, that doesn't mean that there's no value in plants. There is. I mean, there's definitely some value in plants, and to use them. And certainly plant medicine's been around for a long time, but it's not the predominant aspect of a pH 2.0 stomach. That's not what we're supposed to do.
Yeah, no, I agree. And so how do you approach that with your patients then? You know, when you have someone coming in with extremely bad back pain, the surgeons can't do anything with them, and there's just a big mess. What do you first? How do you first approach that?
So the first thing is harm reduction and stabilization, and that is the value of these potent medications and potent techniques. But that's not where you can live. That's not a bridge you can live on. First, you want to help the patient get out of symptoms so that you can start working them up and figuring out what's going on. But the fundamental thing is figure out what their drivers of inflammation are. I can tell you that in studies that we've done in our clinic, in the United States, 93% of the population has severe metabolic inflammation, moderate to severe. In the pain population, it's 99% plus. The only people that don't have severe metabolic inflammation in the pain population are those that are athletes that got hit by a car, and they're coming in and they might have a neuropathic pain because they've got a stump, or they've got some issue that has not been able to spontaneously resolve. But the ones that I see all have chronic inflammation. Almost all of them, whether they're obese or not obese, they have severe insulin resistance. And the typical methods that we use to figure out insulin resistance are inaccurate in this population, in general populations, in fact, because the hemoglobin A1C, which is a measure of diabetes, is wrong 75% of the time.
Hmm.
It really is a function of where you are with your insulin against your glucose and the reactivity of insulin against the insulin receptor. And the vast majority of our patients are insulin resistant or they're pre-diabetic. So the first thing is to get an adequate history. And in that history, educate the patient. And that's where we start. We start with a serious education of where are you? What's your dietary intake? We go through all the usual stuff, but then we pull forward their social determinants of health. What are the things that are impacting their ability to function? What's their financial status? What's their neighborhood look like? I can tell you that in St. Louis, I know these neighborhoods and I know where the crime heat maps are. And I ask patients, oh, where do you live? Oh, I live here. I'm like, so do you live in a safe neighborhood? Oh, yeah, I live in a safe neighborhood. I'm like, how many gunshots do you hear in a week?
Mhm.
Well, yeah, every night.
Mhm.
And so people get desensitized to what's a safe neighborhood. We very quickly, when you live in a potential war zone, we forget that that's not a safe neighborhood. And so understanding that gives you a little bit better information because you know that that person is being awoken multiple times at night. You know that they can't go to a grocery store. They don't have transportation and they're going down to their local bodega and getting fried food and it's enriched in vegetable oil. And they haven't changed that vegetable oil in 6 weeks, 9 weeks, 12 weeks. So it's all oxidized. And that's the beginnings of their neuroinflammation. So you take these histories, you also look at ACEs scores, which is their childhood experiences. And about 40 to 60% of the patients that we deal with have significant underlying PTSD. They just may not recognize it. So you put all that information together, you do your exam, and then you come up with a plan that jives with where they're going to go. And once patients have information, they're able to see a bigger picture. And so it literally takes us 35, 45 minutes to get through the initial history, which is rather unusual because most people go to their doctor and they're like, I got in and out in 15 minutes. Well, you come to us, we see a lot of patients, but that initial intake is going to take us 45 minutes to an hour. And we're going to spend our time. And this isn't a concierge clinic. We see a lot of Medicaid, which is public aid. And we see a lot of Medicare and we see a lot of regular insurance. But if we don't set those parameters up front, the patient's not going to do well. And so we want to front load the education and we give them specific dietary advice right up front. We do all of our biomarkers and that way we can feed the information back to the patient on what to do later. But we draw all that up front and then we get a radiologic exam and then we start on the plan. And we're not just, oh, do lifestyle only. It's a combination of medication, lifestyle, behavioral coaching, interventional technique, and then slowly unwinding the issues.
Yeah. And so how is that approach? I mean, well, how long have you been doing that for starters?
Almost 20 years plus. I
Wow.
started in the adult world with anesthesia, went into pediatric anesthesia, heart, liver, lung transplant,
Mhm.
then went into pediatric onc anesthesia and dealing with all the kids. And that's how I really got into pain.
Mhm.
And then came out of that and did adult pain as well. And so it was a circuitous route. And the reason I ended up here was not because I had some epiphany and saw a burning bush next to a rock one day. That wasn't it. What it was I was doing procedures and there was no durability. Like I could get to the pain generator, but then things came back a few months later. And I
Mhm.
would use the pain medication and I realized, hold on, we're not really getting to the source of the problem. We're creating addiction. And and so I had to reformat and I kept wondering, these people are so poor, how come they're so fat? I mean,
Mhm.
what's going on here? Why are my poor people the fattest people? And historically, the fattest people have been the richest people because there was a show of wealth.
Mhm.
But I'm dealing with populations where people can barely move and they're morbidly obese and they're insulin resistant and they have been diagnosed. And so I had to unwind it. And that's why I got into first, I tried to understand obesity and got boarded in obesity and then boarded in addiction and just trying to like unwind the whole thing. And then I ended up concluding, hold on, the whole thing is collected together. It's called metabolic inflammation. That's the core nexus of what we're dealing with. It's 2/3 of healthcare in the United States. It's a 1.3 to 1.7 trillion dollar problem. It's the primary problem. If we fix that, then we can unwind. And that's how I ended up here.
Okay. And so have you been using these, metabolic health approaches and lifestyle sort of interventions from the beginning, or did you transition that later
It's
on?
incrementally built up.
Mhm.
It didn't happen like immediately. It took me a long time to discard what I had been taught.
Mhm.
Because we don't get much education in nutrition or lifestyle, and you have to be very careful that the advice that you're giving people doesn't run contrary, and then everything that the patient's exposed to and everything as a physician we're exposed to um, is really nutritional guidelines that promote carbohydrate consumption and they dissuade you from meat consumption. Those are the fundamental nutritional guidelines in the United States. Um, and so you really have to unwind and you have to rethink, and you have to spend a lot of time being able to read literature and then be able to defend what you're saying, because if you can't defend it and somebody turns you into the board, then you're in trouble.
Yeah.
And so you better know your stuff, and that's why it took me so long. I understood it, but I had to come up with position papers that would say, okay, I can defend this and I can defend this and I can defend this. And these are the holes in the science over here. So I had to build a dossier for myself,
Mhm.
and then be able to stand up in front of my peers and say, look, this is what I need to do. So I'm the president of the Missouri Society of Interventional Pain. I've spoken at national ASIP meetings. I've spoken at the ADA. I've spoken at a whole host of conferences. And it always amazes me how far from patient reality some of the guidelines are, and those guidelines are basically industry based, not saying that there's you know not saying that there aren't utilizations for those, but a lot of it is so deviated from biology that it doesn't make a lot of sense to me. And so I had to be able to defend it for myself, and to protect my license, because if you're not careful, you will lose your license.
Yeah, definitely. Even if you're getting good results, which is scary.
Yeah, exactly.
Yeah. That's something that David Unwin is doing. Dr. Unwin's a GP, family practice physician over in the UK,
Mm-hmm.
and he was getting thoroughly attacked for his carbohydrate restriction in diabetics that he was doing, and so he started publishing his own case reports and his case series, and now he's got 150 plus confirmed reversals of diabetes and like completely come off medication, and that was again just to defend himself so that he could say, hey, look, this is what I'm getting, these are the results I'm getting, and I'm saving the NHS all this tens of thousands of dollars a year just on these diabetes medications that we're not having to give to these people. And now all of a sudden, everybody wants to know. And where before everyone was yelling at him and saying he was killing people and just terrible and a quack and all these sorts of things. But yeah, it's you have to be able to protect yourself, because there will be anytime you deviate from the norm, someone's going to come after you. Even if there's that saying that if you have a whole crowd of people running towards a cliff, the one guy running away from the cliff is the crazy person, right? So like, what the hell is this guy
Exactly.
doing? So yeah, so that's very good. So how do your colleagues in the pain management specialties view your position on this? Hey guys, just want to take a second to thank our sponsor, Carnivore Bar. I don't promote many products because honestly, all you need to be healthy is to just eat meat. For those times that you're out hiking, road tripping, or stuck at work and you want a nutritious snack that is just meat, fat, and salt if you want it, the Carnivore Bar is a great option. So I like this product not because it's just pure meat, but also because I want the carnivore market to thrive as well. And the more we support meat-only products, the more meat-only products there will be available in the mainstream. So if this sounds like something you'd like to get behind, check it out using my discount code Anthony to get 10% off, which also applies to subscriptions, giving you 25% off total. All right, thanks guys.
It's slowly changing. So when I first presented this 8 years ago, you could have like when I stood up in front of ASIP and 500 physicians in the room and I'm presenting this, they're looking at me like you're batshit crazy. Just put a stimulator in the patient and be done, or just put a pump in and be done. I'm like, but the pump is the wrong idea. The stimulator is the wrong idea. There's high infection rates. You're not getting to the fundamental problem. You gotta. I don't care how good your feedback loops are. Why don't we fix the metabolism? And then if you still need it, then you've got this other technology. But we know that if you're metabolically healthy and you're severely traumatized, your body will heal and it'll turn it off by itself. So maybe if we fix that, we don't need this. And it's not to say that there isn't a good indication for technology. I mean, because people are seriously damaged, and you have to be able to repair that damage, but that doesn't mean that you have to go overboard on medications that suppress the brain and turn off the brain and turn off all of the pathways. And so it's a comprehensive approach. And when I first started, you could have like people were they couldn't even understand or fathom why I would go that way, because one, it's not financially lucrative to do that. In fact, you lose money because you can't do the one thing that generates a ton of revenue. And you look kind of foolish because you're spending a lot of time trying to get it better. But then the patients do better. And that makes a huge difference. I mean, I can tell you that we see a lot of patients, and by a lot, I mean like hundreds a week, 60 a day to 100 a day. So it's a lot of patients. And I've got colleagues that I've trained into this, and we're all kind of pulling in the same direction. We have really embraced artificial intelligence, and we've embraced all kinds of ways to increase our reach with our patients so that we can really do feedback in an appropriate way. And we do a lot of lifestyle coaching and behavioral health coaching. And so we're able to get that done, and brought in a psychologist and brought in people that are all swimming in the same direction. So we created a team of people that think the same way, and that's really helped us. And then as I more recently presented in the last 6 months, I just presented to ASIP again in the last 2 months in Ohio. And I had a room about 150 people, and they were enthralled and they loved the idea. So it's changing. There's been a massive change, I think, because I keep dripping the water on the rock over time, and people are seeing that what they were doing wasn't working. And they also they understood what happened during COVID. They understood that it was a metabolic health phenomenon. And a lot of physicians have recognized, hey, hold on. The people that didn't do well in COVID were the metabolically ill patients. And maybe if we fix that, that would help. And because the US, we lost a lot of people, and it was the dry tinder that we lost. And those are the people that were metabolically the sickest. And it made it a very stark example of what was going on.
Yeah.
So it's much better received now. Now I don't feel like the pariah when I start talking.
Yeah.
And people get it.
Yeah. Like we described there, doing everything you can with diet and lifestyle, going about these approaches, which do take longer. You don't get to bill for them, as you would procedures, which is what, a lot of doctors, pay the rent with. but it works and you get better results. And then if you have a case where it's just not enough, or they're not able to quite do it, or a combination of the two, then you have these interventions. And then there's something like you've done everything that you can in your power to fix this. It's just not quite there. Then you intervene. I mean, that's real medicine. That's what we used to do. They said we had, these medical interventions that allowed us to achieve things that were unachievable. You have a burst appendix, you're septic, now you can go in there and you can clean that up, take out the damaged tissue, sew it back together, and someone can heal. That's something that the body may not be able to do. So that's real medicine. Whereas these metabolic issues that manifest as pain, that manifest as other sorts of symptoms, that's, a lifestyle issue. And that's largely. And so at least the things that you can address through the lifestyle, I mean, we shouldn't just be papering over these underlying issues with symptom control alone, and then just and leave the fire burning underneath, just blow away the smoke and forget about the fire, but then when you address as much as that you can, I think that's the really exciting medicine. That's the real, interesting stuff, that hey, I can do this for you, and you're not able to, your body's not going to be able to do this, and we can fix you. I think that's really the exciting stuff. It would be really interesting to see if we could ever work with the insurance companies to try to incentivize that sort of intervention, because it would save them a hell of a lot of money that they're not paying, millions of dollars a year in, spinal cord stimulators and all this sort of stuff. And I'm sure they'd be thrilled to not have to pay all that. They incentivize, like, hey, if you do these sorts of interventions, or if you publish a series, or a study showing that, hey, we get better outcomes in these patients, and then take that to the insurance companies and say, hey, why don't you pay me to do this, so that I'm not charging you to put in these stimulators and do these expensive interventions, and see what happens. I think they probably would go for it if it's viable, because there's already, well, I went to a conference in Switzerland, and there was the like CEO of, it was one of these Swiss reinsurance companies. They insured the insurance companies, and they were actually really interested in this, because they saw this saving them billions in payouts and life insurance and things like that. Yeah, they insured the life insurance companies, things like that. So, if you could have people, live longer, do better, be healthier, then, they save a lot of money. So I wonder if that might be the way to do it, because there has to be some, well, if we can incentivize this for the physicians out there to spend an hour, instead of like, look, I got 15 minutes and I've got to go on to my next patient, and I can do an intervention and do a procedure, and make a lot of money, versus sit there for an hour and talk to somebody and only bill for one consultation. It's not as desirable for people. I saw at one conference that really bothered me. Someone was telling a story. He was an interventional cardiologist, and he was really interested in preventative medicine, preventing heart disease and atherosclerosis and heart attacks and all these sorts of things. And he was talking to a colleague of his about his interest in this. And his colleague was an interventional cardiologist as well in the UK. And he said, I don't want to prevent heart disease. That's what pays my bills. I don't want there to be less heart attacks. I want there to be more heart attacks, so I can do more stents, so I can take more people to a cath lab, all these sorts of things. I mean, that guy should be locked up. That guy should, be, probably, you know, given a blindfold and a cigarette and put in front of a wall. I mean, that's like, those are the type of things we hung people for Nuremberg trials. I mean, you don't do that. You want more heart disease, you want more suffering, just so you can make money. Like, that's wild. But if you can change the incentives, so, you're not making 15 grand putting in stents in somebody, you're making not that much, but you're making a decent amount of money educating people so they never have to have stents in the first place. I think that might be the way. Well, I think that would help people anyway, get better outcomes.
I agree. It harkens back to the origin of physicians, and
Mhm.
the original origin of physicians, because in the United States, I mean, physicians were really, they were the class of people that were either doing butchering or they were doing hair cutting. And that's the origin of physicians and surgeons. So that's the fundamental basis. And then there was a large group of people that were mostly women that were sorceresses or witches.
Mm.
And so that's the origin of medicine, but it didn't get corporatized. It didn't become like medical school with corporatization until people decided that they wanted to sell drugs and they needed high price salesmen for these drugs. And so that's the origin of why we have medical school, because it was a way to indoctrinate a sales crew
Hmm.
into it and keep a separation between you and the sales crew. And the sales crew makes their money, but they sell your product and they just don't realize it that they're selling your product. And so it's the origin of pharmaceutical sales is a problem. And almost everything that we do in medicine is driven by these large agencies that are trying to figure out how to sell more drug. Because when you make a drug, it doesn't, you do some research, you make the drug. And at that point, like for example, Ozempic probably costs $5 to make a dose of Ozempic, but they sell it for $800 to $1,200 a month.
Jesus.
But it costs $5.
Mm.
Insulin, it costs almost nothing to make, but they sell it for $1,000 a month. That delta is the incentive for those companies to do that, but they can't do it on their own. So they have the physicians do it by manipulating the physicians into saying, "Oh, this is what you need, patient. So here, take this medication." So we end up in bed with the pharmaceutical industry if we're not careful, and and that's pretty classic. That's how it works. Almost all new devices, you end up in bed with the device manufacturer, and the margin is really on the side of the manufacturer of the medication or whatever. In the United States, we have these things called PBMs, which are wholesalers for medications, and they make a ton of money. The hospitals make money because there's programs where they can buy pharmaceuticals at wholesale and then they can sell them at retail and they get to keep the difference, but they got a subsidy to buy them at wholesale. So a lot of the medical system in the United States is driven by medication, and it's the sale of that medication. And it just so happens that physicians are, one of the derivatives is that they were high price salespeople, and
Mm.
and I know that's very pejorative, and I know that people take that as offensive, but that's the origin. And so to separate yourself from that, you have to step away. You
Mm.
cannot accept funding from drug companies. You
Mm.
really have to. Once you get away from that, then it clears your thoughts and you ask yourself, okay, what's the best thing for my patient? Not what's the best thing that this drug company told me to give them, but what's the best thing for the patient? Because I mean, medications are life-saving and we need them. But just because you reformulated it slightly and change the milligram dosage slightly and then put it under a new patent doesn't mean that you should charge an extra couple $1,000s for it. And the reality is that if you're trying to do health and you as opposed to unhealth thrives on misery. And it's like the creature that just lives on the misery of human beings. And we can get away from that if we make human beings healthy. But then that means that a big chunk of our healthcare expenditures will disappear, and it'll radically shift the power in the structure in our governmental influence and things of that nature. So it's a tough thing. It's a tough road to hoe. But at the end of the day, if you want to really help your fellow human being, that's where we should be as physicians. We should be trying to make that radical departure difference that says, hey, my patients don't need this, or I figure this out without this. Not to say that there isn't like amazing stuff that we can do with medication and techniques and procedures, and we need to do those things, but there's other things we can do as well. And then we wouldn't have, we if we incorporated lifestyle coaching and health coaching, it would take more resources in terms of people and and other things, but it would potentially stop a lot of the complications, because these devices and medications also have complication risks, and those complications build up. At least 5% of people are misdiagnosed completely. And then, well, probably one of the number one causes of death in the United States is iatrogenic. We caused it our own selves. We
Yeah.
caused the problem that killed the patient. And we didn't do it on purpose,
Mhm.
but it's a side effect. And so those are the things that we need to kind of be aware of.
Yeah. Yeah, I'd say both my grandparents were sort of let down by the medical establishment, probably would have fallen under iatrogenic cause of death, unfortunately. They were in their 90s, but they didn't need to, it didn't need to happen the way it did, and there are a lot of very well-meaning people that are just in a system that funnels things in a very specific way, unfortunately. And the patient doesn't always get the right end of it. Yeah, it's interesting, how expensive insulin is. That I was looking at, Gary Taubes, who wrote a book called, well, the origins of diabetes and treatment and everything like that. And he spoke about how when they discovered insulin and its use obviously in diabetes and type 1 diabetics in particular, they thought it was, I mean, these guys, I'm pretty sure they won the Nobel Prize for this. And they thought it was such an important thing for the world that they didn't even keep the patent. They sold the patent to the public for $1. Just it was like, no, this has to be everywhere. No one should be, capitalizing on this. It's probably unfortunate they did that. They probably should have kept the patent and then sold it for a reasonable price, because then people got their hands on it, and then they manufactured and sold it for for exorbitant amounts of money. And obviously it's 100 years down the line now. I mean, that was 1921 when they came up with insulin, and now it's they're coming up with all the new different kinds of insulins and things like that, so they can just keep charging more and more and more. And then yeah, and then there's other sorts of issues too. I mean, there was all that weird um, problems with the EpiPens, where they sort of boxed out their competition, and then all of a sudden EpiPen was the only one on the market, and then all of a sudden, boom, it was $400 a pen. And I was like, what are you doing? I mean, you're talking about like kids with a peanut allergy, they're gonna die, and it's just like 400, let's go. It's pretty ghoulish to do something like that when you're talking about saving someone's life. Um, I remember a friend of mine. He was he was from Ireland, and he was playing, a game in the U.S. somewhere. Don't remember where, East Coast somewhere. And he had travel insurance, but then he like broke his arms, sort of distal radius, and so it was real simple. Was in there for a day case, just to do an open reduction and fixation, and just put a little plate in it. And so it was really easy. It was just a day case, didn't even stay overnight. And he got the bill and it was like 50 grand, and he's looking through this like, what in God's name is this? Or maybe it was even more than that. Um, and this was, 15, 20 years ago. And he looked at the itemized breakdown of it, and he found he said that he was in pain in recovery, and they gave him 2 Tylenol, and they charged him $600 for those 2 Tylenol. It was
Yeah.
just wild that they can do that as well. And I guess when you have travel insurance, they'll sort of pay whatever. But I mean, it was just taking advantage of that was just shocking to me.
Well, if you look at so I'll give you an example. It's akin to this. And I looked at, I work with my orthopedic colleagues all the time. In the United States, if you get a total hip or total knee replacement, what do you ballpark is the surgical fee for a total hip or total knee in the US?
Oh, I would say $800 to $1,200,
So
maybe.
yeah, the surgical fee for a total hip is 1375, for a total knee is 1430. That's the surgery fee
Yeah,
in a hospital.
yeah,
But what's the
oh,
fee that they're charge Medicare?
yeah,
It's between 65,000 and
yeah,
$95,000.
yeah,
The bulk of that money goes to the facility.
yeah.
About $20,000 of it, between 8 to 20,000, would go for the implant. But the surgeon is making 1375
Hmm.
to 1470, whatever it is. And they take care of the patient for the next 90 days. And so if the patient has a complication in the next 90 days that's associated with a total hip or total knee, the surgeon's going to have to take care of it gratis.
Mhm.
And that tells you where the incentive is, because the incentive, the surgeon barely making it because it takes them 40 minutes to do that procedure.
Mhm.
And they've got to still pay their office. They got to pay everything. And the surgeon's not making much money. Who's
Mhm.
making the money is the hospital. It's the
Mhm.
facilities. And it's the pharmaceutical industry. It's not. So the average income, inflation adjusted for physicians, has gone down in the United States by 50% over the last 10 years.
Wow.
Inflation adjusted income is down 50%, whereas the cost of healthcare in the United States has gone up by 80% inflation adjusted in the last 10 years. So what's going on here? Why is the physician income down 50% inflation adjusted, but the cost has gone up 80% inflation
Mhm.
adjusted? The difference is that per physician, we now have 10 administrators in the United States who can't practice medicine but work in healthcare. So each physician is pulling the donkey cart for 10 administrators, and they need that physician to work a lot harder so that they can maintain their salaries. There's been a 3,800% growth in administrators in the United States. That's ridiculous. And so we've gotten so far away from practicing medicine that we're basically just we've become the slave class almost. And I
Mhm.
hate to say it that way, but that's what it is. If we stopped doing what we're doing, there'd be a lot of administrators that would be really pissed off
Mhm.
uh, because they need us. But at the same point, we need to help our patients, and we need to be able to spend the time to do it, um, and to do it correctly. And so, and we've just migrated from one catastrophe into another. For example, we have this amazing drug, Ozempic and Mounjaro. These are GLPs, and
Mhm.
we use them to a small degree, but within the context of their what they're used for. So they certainly will help you lose weight because they'll give you gastroparesis. They stop your stomach from emptying. But there's something more important, and that is that they cause your brain to be anhedonic. They cause you to no longer seek that pleasure of the food, which reverses that hedonic cycling. And when you do that, it has a side effect too, which is if you're an alcoholic, you stop drinking. And so if you're a serious alcoholic and I put you on a GLP, you might end up seizing
Mhm.
because you acutely stop drinking because you no longer have a desire. And that's happened to me a couple of times. That's
Oh.
issue one. Issue two, though, is because you get gastroparesis, you can't empty your stomach, so you're not likely to eat, and you can't break down protein. And when you can't do that, you start to get sarcopenic wasting first. And the sarcopenic wasting precedes the weight loss. And that sarcopenic wasting never comes back. So
Mhm.
even when you get off the GLP, once you've gotten to your weight that you think that you should be at, you've gotten there in a way that you've lost your muscle mass, and that muscle mass doesn't come back. You get
Mhm.
off the GLP, all of a sudden you regain the weight, but it's not muscle, and you're at a higher risk of having problems because you're not able to produce the myokines that you need, which are actually anti-inflammatory, and you end up with more white adipose tissue producing more leptin, which has all of the cytokine problems and all the inflammatory issues.
Mhm.
So you're not getting the benefit that we'd want. And what we did was we traded insulin for Ozempic, and they both cost $1,200 a month. So the companies didn't lose any money, but we made the patients sicker over time. And I think that that's going to be our next big thing is we're
Mhm.
going to see patients that we've put onto Ozempic. They've gotten a lot sicker, and now they're skinny fat, and they're going to be even worse than they were, and they're going to be a higher risk of fall and a higher risk of sarcopenic loss.
Yeah, definitely. Um, yeah, I actually I've heard this for years. I'm sure you have as well. That the reason that healthcare is out of control and the cost of healthcare is out of control is because doctors just get paid too much, and they're just all rolling it and things like that. And and that always pissed me off because I actually read an economic report that showed that if you didn't pay doctors a single cent, that it would not appreciably lower the cost of healthcare to the to the people. It would not change anything. We're basic, like you said, when people go, they're just coming to see the doctor, and you're supporting the entire establishment. It's a big establishment. It's a big hospital. These things are like little cities, and you're going to see the doctors. Those are the minority of the people that work there, and they get paid a minority of the fees, and have sort of turned doctors into sort of hourly workers. They're just a wheel in a machine, cog in a machine, and they're just there to churn out office visits and procedures just to generate revenue for the hospital. But they don't see much of that. They're just a sort of an hourly employee, or bill for procedure sort of employee. Whereas it used to be the doctors, would own the practice, would own the hospital, and now you have these big HMOs and massive corporations that own everything and just hire doctors, and then they just feed off them. A friend of mine who's a lawyer sort of equated this to indentured servitude. They've sort of, and school loans as well. You get these massive school loans, like hundreds of thousands of dollars, and you're paying those off for 20, 25 years now, and you're paying back far more than you borrowed, and the interest rates, what, 8.5% or something like that, I think, is on my student loans anyway. And so it's a massive ROI for these people. And I think when I graduated medical school, I had already racked up another $100,000 in interest. It was like, okay, it's like already at the point of absurdity at this point. And then they have you working for them sort of for the rest of your life, and then you're in this institution that you're basically just churning out money. And like you said, you sort of you're in this indentured servitude. We brought you here, we let you be a doctor, but now you work for us for the rest of your life. And it's sort of this deal with the devil that they sort of snuck in on us, because that didn't used to be the way. Doctors used to do very well, and because they had a slice of the pie of the profits, and they would have part ownership in the practice or the hospital or something like that. And like my great grandfather, he was went to Columbia. He was still to date the youngest graduate from Columbia Medical School. He was like 20 years old, couldn't even practice until he was 21, so we had to just go home and hang out, like the 18 Doogie Howser 1800s, and just and then go back to residency after that at Bellevue Hospital. But he ended up in Southern California, and he was like the 13th medical license that California ever gave out, and he helped found Redlands Hospital. And so he was part owner in that, and that was a pretty common thing, that doctors would actually be the ones building the facilities and running them. And now that's definitely not the case, and we've just sort of been suckered into this position where we're just sort of just cogs in a machine and just churning out for other people. And like you say, the only way out of that is to step out of it, just not be involved in the first place. And you also get to practice better. You actually get to practice real medicine. You actually get to do the things that you see helping your patients, instead of just doing what you're told because that's what the hospital says you need to do. Dr. Sean Baker, he got drummed out of his practice. He was head of orthopedics at his group in, I believe, New Mexico at the time. And because he started coming to these metabolic therapies for people and getting them better, so they didn't need joint replacements, and he was really happy with that because his patient was doing better. But it was really pissing off the hospital because they weren't able to bill $70,000, per joint replacement, and they made some trumped up charges and tried to get his license taken away to get him out of there. And it didn't stick. They didn't take his license away. They just investigated him for a couple of years and then said, yeah, there's nothing wrong. And but it's very it's very disenchanting with the whole system, that because you're doing real work for your patients and real benefit for your patients, that your hospital tries to destroy you and destroy your career and your medical license. It's absolutely wild. Hey everyone, really happy to announce a new sponsor for the show and for everybody down in Australia, Stockman Steaks, who are delivering high quality grass-fed and finished pasture-raised beef and other meats, flash frozen and vacuum sealed to your door, something that I've been enjoying a lot of myself recently as well. They also have a great range of specialty items such as high-fat keto mince and carnivore beef and organs mince with liver, kidneys, and beef heart as well. So use code Chaffee today for a free order of beef mince or another specialty gift along with your order at stockmansteaks.com.au, and I'll see you over there. Thanks, guys.
Yeah, I mean, but from their incentive standpoint, they don't want you doing that. You're
Yeah.
taking money out of their mouths, and they need you to do those procedures. They have to live on the misery of that patient.
Mhm.
And it's they're not practicing healthcare; they're practicing sick care,
Yeah.
and they need that patient to be sick. They need the patient to be severely diabetic so they get an amputation. If we eliminated type 2 diabetes, 2/3 of our hospitals would have to close. I mean,
Wow.
it would be done. And yeah, it would be a better world, but 2/3 of the hospitals would have to close because those are the inpatient centers that we don't any longer need. Um, and so it's a challenging situation. There's always going to be a need for healthcare. There's always going to be a need for acute care. There's always going to be a need for certain things. But a lot of this stuff is iatrogenic. We've self-created it as a society, and it's 2/3 of our healthcare expenditure in the U.S.
Mhm.
And we need to fix it. We need to unwind it. And it's doable, and patients want to do better. That's the other thing. So like, for example, I get a patient in, and and as I said, hemoglobin A1C underrepresents diabetes, but if their LPIR is high and they're starting to rise their hemoglobin A1C and they're getting into beta cell fatigue, then my first step is that educational component, but then putting a CGM on them. Because once patients have a gamification process and they can see that what they're eating impacts the glucose in a real time, that they're not checking their finger stick, but they're actually seeing that interstitial glucose change in real time within 40 minutes of eating, they can see it. They go, oh, that's what's making my sugar go up. And I guarantee. So what's interesting to me is when we've done this in our own clinic, we did a very brief, short study, about 50 patients. Every one of them, almost except for two, dropped their sugars, and we never had to go forward. That lifestyle change with a hemoglobin A1C between 5.7 and 6.4 with a CGM, they immediately changed their lifestyle and they never went forward. Those patients never had to go forward. Now, the thing is, it is glucose, it is the carbohydrate, but there's other factors, and it's the lipid raft and
Mhm.
the omega-6 to 3 fatty acid ratio. It's all of those other factors that we have to fix as well. And then as we unwind it, their whole body gets better. The vitamin D gets better, their sun exposure gets better. There's all kinds of tricks that we've got to really make these people metabolically healthy. And yeah, we certainly will use medication, but judiciously. Um, and it's silly stuff like vitamin K2. We want to reverse cardiovascular disease, so we use vitamin K2. K2. We want to reduce the calcification. In the U.S., you can't buy a calcium artery. You can't do a CAC score on a patient under their insurance, so they have to pay for it. And CAC score, once it's high, it's really hard to reverse because the calcium stays. But if you give them vitamin K2, it helps. Nattokinase helps. So there's all kinds of lifestyle tools that we can use to improve them. And as you use those tools, you get them off their meds. You get them out of their chronic pain. And you bridge them the whole way so that they're not suffering. One of the biggest things that I find is the patients come to me, they've already been treated by somebody typically, and they're coming in on benzos. They're coming in on benzodiazepines like alprazolam or Xanax. They're coming in on high dose narcotics. Our average incoming patient is on about 140 to 160 milligram morphine equivalent.
Wow.
And within a month, they're on less than 40. Our average patient's coming in and they're on 2 milligrams, 2.5 milligrams of Xanax. And within 6 months, they're off. But you have to do it judiciously. You have to tweak them and recognize what those things are. Like we have an epidemic of everything. We've got an epidemic of impotence. We've got an epidemic of anxiety. We've got an epidemic of pain. We've got an epidemic of obesity. We've got an epidemic of diabetes. All these epidemics are all the same thing. It's metabolic inflammation. It's your health system. It's all of those things are interrelated.
Mhm.
And so you have to spend the time to figure out what it is. Does the patient need a gut microbiome reset? Does the patient need a sympathetic reset? Can I use GABA aminobutyric acid to calm them down at night? Can I change? Do they have a PTSD? And should I have them get a dog who's going to help protect them at night and get them to turn their TV off? It's a whole host of factors, and it's pretty complicated if you don't categorize it. And that's what we've gotten good at over the last 20 years, is categorizing the problem and then trying to pick the technology that meets that social environment's necessity. And everybody's in a different demographic class. Everybody's in a different economic class. So a tool for one person is unaffordable for another, but you have to figure out another way.
Yeah. Have you published those results on how you can your patient coming in and being able to reduce them off their pain med?
We've done some publication on it, and we've presented an abstract, and I've got a more comprehensive group of publications that'll probably come out next year. That'll
Nice.
be more widely distributed. I've done some publication stuff, but there's to give you an example, we did a very simple study, and the reason I did this was because I kept wondering what am I missing here. I would have patients that, because we use BMI as a calculation, body mass index, even though we know it's not terribly accurate. We use BMI to figure out somebody's weight, and I would look at somebody and go, that BMI can't be 30. That BMI has got to be higher. I'm looking at their height, looking at their weight, and then I realized there was a discordance. My staff were accepting the words of the patient. So then I said, okay, look, we don't accept the words of the patient anymore. Yes, I know that we routinely weigh them, but I want you to routinely measure their height. I found out that the average patient was 1.7 inches off on their height, which completely destroys their BMI. When they come in, I always ask them, what do you weigh and what's your height? And until you measure and weigh them, they give you bad numbers. They're usually 20 pounds fatter than they are. And and they typically think they're about almost 2 inches taller than they are.
Mm-hmm.
And I don't care who it is. And that really changes those numbers. And if that's the basis of what most primary cares are doing, if that's the basis of our healthcare system, where we accept the word of our patient for height, that really changes a lot of information from a BMI standpoint, which then changes your renal function calculations, which changes practically everything. And so understanding that patients have this ego that they want to be taller and they want to be skinnier, which that's the nature of human beings. As soon as you figure that out and you correct for it, and then you're able to give them exact information and say, okay, this is where you're actually at. This is where we need to go. Then it allows you to reset. And there are other biologic tools that change in real time. Like I said, CAC, coronary artery calcium score, is not something that you and I can get to easily on a routine basis, and it doesn't change over time. But plethysmography does. So, which measures nitric oxide production. It's an ankle brachial index. It's cheap. It can be done in your office. And you get a score that tells you an ABI score, and it tells you their nitric oxide production and their vessel elasticity. And you can get it in real time. And as the patient changes behavior, that ABI changes. And it gives the patient a gamification technique to self-manage. And so we have a whole host of tools that are direct and give real data to the patient so that they can self-manage. And the whole goal here is to put the power of healthcare back in the hands of the patient. Because, we should really be the Sherpas that guide our patients, but it's really the patient's journey. And my goal is to put that power back into the hands of the patient and then give them the information they need just in time so they can make a decision. They don't need to go to medical school, but they need to get the right information at the right time. And it needs to be true information, not some information that's been manipulated so that we can sell more drug.
Yeah.
And that's the purpose of a physician. We're actually supposed to be guides. We're supposed to be Sherpa, and we take our patients and we protect them, and we have to protect them from the trolls, and we have to get them along this journey. And those trolls, unfortunately, happen to be the system, the healthcare system itself. We're supposed to guide them through it. If we get to that, our patients will really trust us, and they'll follow what we want them to do, and they'll be healthier for it.
Mhm. Yeah, that's the getting them the true information is so important, and even physicians understanding what the true information is, because like you said, we're sort of set up as these drug dealers without even realizing it. We're just pushing a product, and we think we're the decision makers. We think, oh, I have all these tools at my disposal. I'm the one making the decisions, but really we've just been sort of manipulated and put us in place to you know uh, you know sell their wares. But that true information is very important. And I was listening to an interview with a professor at MIT, and she's a you know, PhD researcher and professor at MIT. She's been there for years, and has been doing a lot of research on glyphosate and how seriously harmful it is. Destroys the mitochondria. It's a endocrine disruptor, and it actually has an inverse relationship, inverted dose relationship with its endocrine disrupting ability. Like the lower the exposure to glyphosate, the worse the endocrine disruption. And there have been experiments showing these sorts of things, and how long term, like there's a guy who recreated the the animal studies that Monsanto did for glyphosate, saying that this was safe and could be used. It was animal studies, rats, 3 months, and they said, look, there's no problem, there's no harm. And so he did the same thing, but he let it go out for the entire lifespan of the rats, and it turns out they were horribly sick. They had all sorts of tumors and illnesses, and others, just massive amounts of problems, kidney failure, all these other sorts of things, because it's a slow poison. It takes time. And so Monsanto sort of gamed the research, and stopped the research before it showed any sort of symptoms, and said, oh, look, it's safe, and then didn't talk about how horrible it got after the fact. And she said that the game's pretty rigged. And so she says it's very difficult to publish anything on the adverse effects of glyphosate. And she said that she's had some things published, and then the people that this would have hurt to have this published came after the journals, and they sponsor the journals, and they pay a lot of money for these journals. And I think that is exactly why they do it, is to buy them. And so they do this with there's some of the major, these big drug and food and drug companies are the major sponsors for media outlets. All the newspapers and news organizations. They're the major sponsors, and a major reason for that is that they're not going to be dumb enough to bite the hand that feeds them and put out a story that goes against them and shows them up for what they are. And they might go out and defend them, when something comes out against them. And but she was saying that these big companies would actually go after the journal and just put a lot of pressure on them, saying, okay, you can't publish this, you have to retract it. And they ended up retracting a lot of her papers on glyphosate. And a lot of them don't even get published in the first place. And I can't imagine that doesn't happen with big drug companies as well. I mean, they have a huge influence, financial influence, on these major papers as well, these major journals as well. And so, the papers and studies that are coming out against them are going to be very hard pressed to actually get published in any of these journals, which skews the literature and makes it so you can't really trust the literature anymore. The vast majority of nutritional research is paid for by the processed food industry. They spend 11 times the amount of money on nutritional research than the NIH. So they're putting out all this money, putting out quote unquote research that's really just marketing for their product, and then they attack any paper that might be coming out against them and can prevent them from even being published in the first place. And this, MIT, I mean, you don't have any more bona fides than being a professor at MIT. I mean, you should be able to publish sort of anywhere, and she used to be able to, and now she can't, right? Because now she's publishing on something that the powers that be don't want her to publish on. And that really skews the message as well, even for doctors that are really trying to do the right thing. You have to dig and you have to search, and a lot of the really good research is going to tell us what's actually going on, and what we should be doing as physicians and people, is not even being published in the first place. It's actually quite concerning.
Yeah, I mean, like, for example, there's another component to this too. It's not just the publication, it's also the regulation. And
Mm.
it's the governmental regulation, because there's a continuous exchange of people at the top of industry who are paid for by the industry, who then become regulatory. They go into the regulatory system in the government, and then they come out of the regulatory system and go back into industry, and this circles continuously. So that creates a moral hazard. And one of the classic moral hazards associated with that is Alzheimer's. So we've got Alzheimer's, and Alzheimer's is very interesting because we've gone down the pathway that Alzheimer's is a tau protein issue.
Mm.
And tau protein certainly is a accumulation of fibers in the brain, but is tau protein the problem, or is it the accumulation of it? It's similar to the heart, the cholesterol hypothesis for the heart. Is the cholesterol the problem, or is it that the cholesterol accumulates in the area of the damage, and that's what we're seeing? And slowly we've migrated. Finally, people are starting to recognize that cholesterol is the band-aid that the body's applying to the injury area, and that's where the foam cells are. The tau protein is very similar, but there is probably an issue of the tau protein representing the inflammatory state. And when you're hyperinsulinemic, the compound that breaks down tau protein is called IDE, insulin degrading enzyme. So when you're hyperinsulinemic, there's a pleiotropic effect that either it breaks down the insulin or it breaks down the tau protein. And if you got too much insulin, it can't break down the tau protein, so it accumulates. That's why we call Alzheimer's type 3 diabetes of the brain, because you get this cognitive impairment. Now, what's interesting is if you are at risk of dementia, you're ApoE4 homozygous with a 95% at-risk rate of dementia, I can put you on a med that's between, at the low end, $35,000, at the high end, $88,000 a year. And the benefit to you is 1%,
Ugh.
maybe. And if instead I put you on a lifestyle coaching program, the benefit to you is 40%.
Mm.
Now, that means that I probably saved at least $32,000 to $85,000 a year. That means that money didn't go to the pharmaceutical company, but you probably got better almost 50% of the time, as opposed to 1% of the time. But we approved this drug by the Food and Drug Administration, even though some of the researchers said, "Hey, this is not a good drug. It doesn't make any sense. This is not a good drug." And so, but they were overruled. And in fact, researchers quit the panel, saying, "Hey, we can't approve this drug. It doesn't work. It doesn't do anything." But they still approved it. And once a drug gets approved by FDA in the United States, that means that our Medicare system will go on to pay for it. And that means that that company will make a lot of money.
Mm.
And so it's in their best interest to slightly manipulate the system to maximize their revenue, which may not be in the best interest of the patient. And so as a good physician, you have to guide your patient. Hey, there is this drug, but it doesn't work that well. And this is what it actually does. And if you did this lifestyle change, you might get more benefit. What would you like to do?
Mm.
What would your family like to do? And then you can make a decision. But you have to have integrity, and you have to be able to see both sides of that coin. Unfortunately, if all you're doing is looking at Doximity and Medscape as your source of information, those are sponsored. And if you're looking at journals, those are sponsored. And so you really have to look beyond the journals and to have a conversation and to look at the statistics. And a lot of those stats are present in the literature, but people ignore them. and we look at the highlights, and we look at that abstract and go, oh, okay, that's what this says, and then we don't dig into the stats, and it's hard to navigate that, and that's one of our biggest problems. But it's that continuous feedback with regulation. It's the overarching control of the literature. It's kind of like it's what YouTube and Facebook have done to social media and changing people's political perspective. It's very similar. It's akin to what's happening to physicians, or has happened to physicians over the last 10 or 15 years. We've had our opinions changed based upon what we're being told.
And the revolving door policy, where you just sort of going in and out with government, and then going straight into some sort of board executive on the drug companies and things like that. We were just regulating, and it could be like you have to wonder if that's a quid pro quo sort of situation, that you did some approved a lot of drugs that made them a lot of money, and now they're happy with you, and you get some cushy job afterwards. That's certainly the accusation anyway, and it's probably founded in most cases. I know you have patients coming on in a second. I just wanted to sort of be remiss if I didn't ask, because I see a lot of patients with things like fibromyalgia, and just generalized pain, and a lot of doctors have no idea what to do. It's sort of half of them don't even believe it exists. It's just in their head, and they're just drug seeking or something like that. But I see this really affecting people's lives, and I've seen them recover from it as well, and people coming off their opiates and things like that. Do you treat fibromyalgia as well, and what has your experience been with that?
Yeah, we treat it all the time. So fibromyalgia is a description of multiple trigger points above and below your waist, so upper and lower extremity, and it's a multitude of trigger points with a defined set of characteristics, and it's a diagnosis, but it's not a disease process in it of itself. It's a diagnosis, and it's associated with other things. I don't know if you realize it, but there's good published studies that show that metformin works on fibromyalgia.
No,
And there's actually several studies on this. And the treatment of fibromyalgia is to treat their insulin resistance. And if you can get to that, it'll help. And then sleep restoration. And typically it's a gut microbiome issue. And so we get sleep restoration, and we make sure their insulin resistance is improved. The trigger points are of no benefit. Acutely, they can help you to get you out of the mess so that you can sleep and be more comfortable right now. But doing repetitive trigger points is of no value. And a lot of the neurolepts that we use have limited utility. So a lot of the antidepressants really don't have much benefit. And I don't even know where they got the studies to say that they did benefit, because if you look at the outcomes, they don't work. And narcotics really don't have a place in fibromyalgia. There really is no indication other than to create a dependence on them. So we really get away from narcotics. We do stretching, we do everything that we can biomechanically, and then we get their restoration done as in terms of their insulin resistance. And the studies are published already. These are peer-reviewed, placebo-controlled studies that show that metformin works. And so why not use the drug that works, and go down that road? Now, sometimes, though, what's been diagnosed as fibromyalgia is not fibromyalgia, because you'll find out that some of these patients, at least a third to half, have a radiculopathy, either cervical or lumbar, and it's been missed. Somebody has completely missed the radiculopathy, and you got to get to that and figure out that diagnosis. Or somebody's missed the osteoarthritic change and the peri-joint muscle stabilization that's occurring. The reason why you get muscle pain around a joint that's inflamed is the body naturally tries to immobilize the joint till it heals. And that's what happens in your lower back. If you injure your lower back, you get paraspinous muscles that become really taut to keep you from overutilizing it and to protect your spine temporarily. And then if psychologically you feed into it, and you become overly sedentary for too long of a period of time, you actually get sarcopenic loss, and then the immobilized joint becomes arthritic, and you start to get bony spicules in the joint. and then it creates this terrible loop of symptom. So you have to unwind that loop.
Yeah. Okay. I spoke to one researcher on the subject. They don't treat this, but there's something that they sort of came across, was that they found some evidence that it could be also to do with like a taurine deficiency. And
Mhm.
interestingly, we make taurine, but we make it in the liver. It gets expressed in the bile, and then we eat a whole bunch of fiber, which binds the bile and eliminates out the bile and the taurine. And so people are
Mhm.
end up being taurine deficient, even though we make taurine. And then they're eating less meat that has taurine, and eating more plants and fiber because we're told that's good for us, and we're pulling out our own taurine, and then that can be contributory as well. Have you come across that yourself?
Yeah, it's part of the stack that we look at
Hmm.
for patients. I mean, what we're doing is we're analyzing what they're doing, and I mean, our stack of supplementation, it can be extensive. It's everything from, does the patient not have enough leucine, and are they not, don't they have muscle mass? Taurine is a routine that we're using, between 4 to 6 grams a day. Do they need an omega-3 supplementation? We prefer krill oil because it has astaxanthin in it, which is a terpene, and it's an anti-inflammatory, and it's also a slight analgesic. Um, and so there's a whole host of different supplements that are relatively inexpensive, that you can get to that do make a difference. Um, some of the things that we've been playing with more recently, and trying to help our patients, especially the ones that are a little bit more sophisticated, that kind of can see their body changing over time, is things like C15, carbon 15, the fatty acid. Um, Looking at that using urolithin, for patients with defective mitochondria, especially post COVID.
Hmm.
There's a whole host of techniques that are supplementation, and a lot of biofeedback too, a ton of biofeedback, heart rate variability. That's one of the simplest biofeedback systems that we've got, and box breathing is amazing to calm people's central nervous system down, but use an Apple Watch because you can get a heart rate variability right on that, on their Breathe app. As soon as you teach people how to calm themselves down, their cortisol drops and they're able to focus a little bit better. So there's a whole host of tools that are lifestyle that are easily accessible. Taurine is certainly like, it's one of the, I think it's one of the crux bases
Hmm.
of of dietary intake, and it's one of the early things that we talk about with our patients.
Great. Well, that's great. Dr. Padda, thank you so much for that. I know you have patients showing up in a couple
Yeah,
minutes.
yeah.
I won't keep you, but I could definitely keep talking to you for a while. It was absolutely a pleasure. How do people find you, follow your work, and come see you if they need your help?
Probably the easiest way is, well, I'm on LinkedIn. That's the easiest way to reach me if somebody has a question or something. PainMD.tv is our, www.painmd.tv is our pain site. But we also have a reversing diabetes site, and we've got a fitness site and all that other stuff. But shoot me a question through LinkedIn. That's probably the easiest way. I find that I can respond in real time. But if somebody wants information on painmd.tv, we've got tons and tons of like lifestyle and pain based, articles, and it kind of weeds through the the junk and says, "Hey, this study didn't make any sense because of this. Consider this instead." And so my goal. So I grew up in India, and I left India when I was very little. When I was very young, it was like 9, and in India, we didn't have a lot of resources. And so you're always trying to figure out bang for buck. You're always trying to figure out, how do I get the maximum value for the least amount of resource? And that's one of the fundamental drivers, of how I approach this. How do I make patients better without doing too much? Just doing what they need, and then giving them the opportunity to get as best as we can, and then going forward. Um, and so a lot of the articles that we've got on PainMD talk about those techniques. Like, improving your vitamin D through walking in green space, even if you can't tolerate the sun, getting up early, having a routinized schedule, and having appropriate sleep hygiene, and the impact that that makes on outcome. How do you deal with PTSD, and how do you deal with other alpha predators? Like, I have a lot of veterans that have been blown up by IEDs, and so one of the things we discovered was that once we took these veterans with their PTSDs and we introduced them into the wolf sanctuary, which we have one that's pretty close,
Ah.
the one wolf recognizes the other wolf and they both calm down.
Mm-hmm.
And so we have an arrangement with one of the local animal shelters. We're always like, okay, so and so is coming in, and see if you can introduce them to a dog that they can walk around and be friendly with. I can't tell you how many adoptions we probably facilitated through the animal shelters, just because we think that those connections are well worthwhile. You get a tremendous oxytocin release from being next to one of those animals, and they also get that oxytocin release, and there's a bonding that occurs. And loneliness is a big problem in the US. So we're always trying to figure out that lifestyle thing that's going to make a difference. And trying to come up with as many different tools as possible to make a difference. So that's the easy way to reach me: painmd.tv or LinkedIn.
Perfect. We'll put those in the description, and if people want to reach out, they can go there. Dr. Padda, thank you so much for coming on. It's
Sure.
been an absolute pleasure, and it's great to see you again.
All right, thank you. I appreciate it.
And everybody, thank you for watching. Hopefully you enjoyed it. If you did, please hit the like and leave a comment. Let us know what you thought of the episode. And if you are someone who suffers with chronic pain and you've addressed it with these lifestyle means, please do leave a comment to let other people know what your experiences has been, because a lot of people are really inspired by those comments to try it themselves. And that's something that helps a lot of people. So please do consider that. Thank you, everyone. We'll see you next time. Hey guys, thank you very much for taking the time out to listen to what I had to say. If you like it, then please like and subscribe to my YouTube channel and podcast. And if you're on YouTube, then please hit that little bell and subscribe, and that'll let you know anytime I have a new video out, which should be every week, if not more. And if you could share this with your friends, that would help me get the word out and let me know that you like what I'm doing. Thanks again, guys.